this flow. I will starting every flow of this session, sir. First, I will introduce everyone, then speaker will speak. Or Pallavi ma'am, please go ahead with
Sir,
the
we are live.
YouTube live.
Sir, we are live. I am
Okay.
sharing the first slide. We are live. Thank you.
मला वाटतं तू ओपनिंग कर आणि सागरला मग इंट्रोड्यूस करू दे स्पीकरला.
Good evening, everyone. Good evening, respected dignitaries, senior faculty, dear colleagues and friends. Myself, Dr. Sachin Patil, Scientific Co-Chairperson MAHA-IP 2026, along with my co-moderator, Dr. Sagar Wag sir, Central IP EB 2026. On behalf of Maharashtra IP, we welcome you all for this Masterclass session, episode number 05. Today's specialty is Masterclass on Pediatric Dermatology. And we have two eminent speakers from Maharashtra, respected Dr. Sridhar Ganpati sir from Mumbai and Dr. Sanjay Mankar sir from Pune. So now I request our respected President MAHA-IP, Dr. Sanjeev Joshi sir, to welcome the August gathering. Over to you, Sanjeev Joshi sir.
Namaskar. Warm welcome to all on this virtual platform of the Maharashtra IP. Today is, I think, the 5th episode of the Masterclass, if I'm not wrong. So I welcome all the dignitaries, luminaries of the Maharashtra IP, Central IP, and especially our both the masters who will be delivering their talks today. They are none other than Dr. Sridhar Ganpati and Dr. Sanjay Mankar. Both of them are astute academician, clinician par excellence, and I think they are not only known at a Maharashtra level, but they are well known pan India. Today's topic is the skin and the pediatrician. Friends, even though we have lot many dermatologists in your town across the state, but the first point of contact for anything goes wrong with the largest organ of the body are the pediatrician colleagues only, and almost 20 to almost 25% of the chunk of the pediatric OPDs has some or other skin issues. And I am pretty sure both of our experts today, they are going to explore more than skin deep. And of course, your expertise will empower our practicing pediatrician about the common skin conditions in their day-to-day practice, especially the diagnostic precision, the treatment protocols, and of course, how to differentiate a common benign condition from a very sinister disease. And it is the saying that in neurology that what the brain wants to hide, the skin reveals. So those are the special neurocutanestic matters. Okay. So our aim in the Maharashtra IP webinar is very simple. We want to give our audience standardized protocols about the common situation, and skin diseases are one of the commonest condition, and I'm pretty sure at the end of this session our virtual audience will be back full of take-home messages. So express my sincere gratitude to both the masters, Sridhar and Sanjay sir. Over to you, Sachin and Sagar. Thank you.
Thank you, Joshi sir, for your almost encouraging guidance. Now I request Dr. Bela Verma ma'am, convener of Maharashtra IP, to address the online gathering.
Good evening, everyone. And I'm really looking forward to hearing Dr. Sridhar Ganpati, whom I call a walking, talking pediatric encyclopedia, and very important topics today on dermatology, on which both the speakers are going to enlighten us. As Dr. Sanjeev Joshi has already told, they form a major chunk of our practice. And these common skin conditions should be known to us because every time we cannot keep referring to dermatologists. We should know which condition needs more further reference. And the common things like even scabies are not picked up by residents nowadays. So I think today's topics are extremely important and will definitely enlighten us further. So welcome the faculties for today and welcome all my colleagues on the platform.
Thank you, ma'am. Now I hand over the mic to Dr. Sagar Wag sir for further proceedings. Over to you, Sagar sir.
Good evening, everyone. Dr. Sanjeev Joshi, sir, President, Maharashtra IP, Dr. Bela Verma, Convener, Maharashtra IP, Dr. Sachin, Co-Chairman, Scientific Committee, and today's speakers, Dr. Sridhar Ganpate and Dr. Sanjay Mankar, sir. Today we have two eminent speakers, and both the topics which are there, the common pediatric skin infections and decoding white spots. So, Dr. Sridhar Ganpate, he is the medical director of Janvi Children's Hospital, ex-editor, pediatric newsletter, Newscraft, and Journal Insight, mini fellowship in pediatric sleep medicine from Australia. He has many dermatological contributions like skin and the microbe multiple presentations, chapter on hypopigmentation, IAP, STG 222, multiple videos on dermatology on the steeper platform, in process of publishing a book on trichoscopy. So the topic which Dr. Sridhar Ganpate sir will be addressing, decoding white spot. आपल्याला कॉमनली ओपीडी मध्ये सगळेजण येतात, डॉक्टर साहेब याला चेहऱ्यावर व्हाईट स्पॉट आहे 1 महिन्यापासून 2 महिन्यापासून. सो देर आर मेनी डिफरन्शियल डायग्नोसिस, फॅट्रेस अल्बा, टिनिया वेसिक्युलर, वेटिलिगो, देन पोस्ट इन्फ्लेमेटरी हायपोपिगमेंटेशन. सो ह्या सगळं डिस्कस करण्यासाठी आपण सरांचा द एमिनेंट स्पीकर डॉक्टर श्रीधर गणपती सर, आय वेलकम सर अँड आय हँड ओव्हर द माइक टू सर.
Sridhar sir, kindly share your
Sridhar sir.
presentation.
I'm just trying to see where my slides have gone again. That's
Sridhar sir has
Sir has left,
Log
sir.
out.
Yeah.
Must be rejoined.
He must be rejoined.
Till that
Yes.
time, I think Sagar Wag sir, please introduce Sanjay Mankar sir also.
Yeah, Dr. Sanjay Mankar sir is from Pune. He is a professor of pediatrics and infectious disease, Bharati Vidyapeeth Medical College, Pune. Am I audible?
Yes, sir.
Yeah. And a practicing pediatrician and infectious disease consultant, Pune. He was a past president of IAP Pune. I welcome sir on this platform, and he will be speaking on common pediatric skin infections, which is a very important topic in day-to-day practice. So I welcome sir for the lecture.
Sir has not joined.
can I share?
Yeah.
Sir has
No,
left?
no, he had joined. He had joined. He had
Yes,
joined.
yes.
Yes, sir. PPT is visible. Kindly make it full screen.
Make it on the full screen. Okay. Audible
Yes.
and visible?
Yes,
Yes,
sir.
sir.
Thank you.
Perfect.
Sorry for that technical glitch. I think the whole session has been summarized by the 3S out there. I think thank you, Sachin. Thank you, Sagar. Thank you, Sanjeev. And thank you very much, Bela, a wonderful person full of humility. Thank you very much for the invitation. And this is something which is most scary in OPD practice, the white patch on the face. In dark skinned people, a small patch of whiteness is enough to cause enough ripples. And we are going to see how to go about it because 9 out of 10 can be treated by the pediatrician, like Sanjeev was talking about. And I think Sachin and Sagar are also emphasizing on the fact that it's simple conditions where there is no need to panic, and there are very few of them which require a referral to the dermatologist. Like in the management of any condition, there are 3 pillars. You need to understand the problem before you start your therapeutics. You need to use a big chunk of common sense. You need a very good history and you need to read a lot. Now, that is the basic for every medical condition that you come across. So let's go through the 3 things. So what gives the skin color? So what gives our skin color is basically the melanin, the hemoglobin in the reduced and oxygenated state, and there might be a little bit of contribution from carotenes. Now, when you look at melanogenesis, you would know that there are 2 types of melanin that are produced. If you take a fair-skinned or a dark-skinned person, the number of melanocytes that they carry is more or less the same. It is the melanin production that is different. So when you get eumelanin, it gives you the dark color, brown to black. And when you have a pheomelanin, it gives you the red-yellow type of tinge to your skin. And it's the melanocytes that start as melanoblasts from the neural crest at the back, and then they come to the front, and then there is the production of melanocytes, and then you have the melanosomes, which are filled up with melanin, and there is a ratio of a single melanocyte to the number of keratinocytes that they connect to, because the melanocytes are the basal layer of the skin, and the ratio is usually 1:36. Number of endocrine factors, we all know that ACTH, MSH are 2 of the main hormones that are responsible for giving skin color. We have a lot of genetics coming into play. We have genes taking care of tyrosinase. So what that basically means that you have a phenylalanine and tyrosine playing a very important role, and there is conversion to DOPA by these tyrosinase enzyme, which are also run by proteins called the TRP proteins 1 and 2. So there is so much to the basic mechanism of production of melanin. In addition to that, you have stimulators like the UV light, certain drugs, which can also bring about an alteration in skin color. And the most famous among the drugs is chloroquine, which we always tend to neglect. So first let's using common sense. So we had this 16-year-old girl who started developing this so-called white patch right in the middle of her forehead between the eyebrows. And when we sat and took down a history, it all started off after she started using a bindi. So we first thought of contact dermatitis with secondary depigmentation. But what actually, when we read about this is chemical leukoderma. The gums that are used on the bindi, they are the ones that bring about discoloration or depigmentation of the skin. So you need to get into the history before you jump into any form of conclusion looking at the particular site. So how do we go about assessing a white spot on the face? First, we take the age into consideration. So if it is there right from birth, it's probably something that is congenital. We are not going to be talking about diffuse pigmentary disorders, like if you have a copper deficiency or the Menkes type, or you have a phenylketonuria. These are conditions where you have dilution of the pigment all over. We are talking about only the ones on the face. So here you could have something called as piebaldism. You could have something called as overlap syndromes with piebaldism, like the Waardenburg syndrome. I'll show you photographs which will make it much more interesting. Then we look at distribution. Now, if the distribution is in the sebaceous areas, we start thinking whether it is a contribution by a fungus like Tinea versicolor. If the distribution is in the photoexposed areas, we start thinking of polymorphic light eruptions. Then we look at comorbidities. If a patient is on immunomodulators, immunosuppressants, then we again think in terms of an overgrowth of the normal common cells that we carry, like malassezia, which can bring about a pigmentary dilutions or hypopigmentations because of the various factors that they elaborate, like azelaic acid. Then the Kobener's phenomena. If you start seeing white spots in areas where there is trauma, like around the knees, around the elbows, where you wear your slippers, you know if you have a white spot, which is porcelain white spot, absolutely white, this could be vitiligo. Autoimmunity, there is not so much of autoimmunity with childhood vitiligo, but yes, that could be an association. We usually search for other autoimmune conditions because one of the theories for vitiligo is an autoimmune process, which could be at the skin level or it could be roomed in from the galt or the malt to the rest of the body. So autoimmunity, so what we do look for is alopecia areata, we look for pernicious anemia, we look for diabetes, we look for all the other types of autoimmunity that could be associated, but thyroid is right on top of the list when you have vitiligo. Then in case of a suspicion of an infective cause for a white spot, so one of the infective causes that causes a white spot other than the fungus, and you're thinking in terms of a bacteria, is a Mycobacterium leprae. And here we start looking out for an index case in the family. Because when you have a white spot on the face, the classical things that we get in leprosy, like the anesthesia or the hypostasia or the alteration in sweating, all those could be missing. So it's always better to look out for the index case. Then we start looking at seasonal fluctuation. What do I mean by seasonal fluctuation? If you find that a particular hypopigmented spot is looking very prominent during summer, this is because the normal skin gets tanned, whereas the abnormal skin is not tanned. So this is a feature of pityriasis alba. Light exposure. So when you are thinking in terms of polymorphic light eruptions, again, you would start thinking in terms of the photo-exposed areas. This is something called as sun poisoning. Then we have the progression. It's like in anything, you need to take a good history. It is his or her story that tells you everything. So when you look at progression and there is a sudden rapid progression. So when you have a sudden rapid progression, especially when you have a white patch on the face, which looks porcelain, segmental distribution, that is, it doesn't cross the midline and progressing very fast, yes, it could be vitiligo. When you have an initial burning and then itch, and you have repeated episodes when there is exposure to the sun, you again think in terms of polymorphic light eruptions. And never to forget the iatrogenic causes. Today, a lot of people get into all types of applications. The fairness creams have hit the market in a very big way. There is so much of a fascination for all the fairness creams. So you have right from Fair and Lovely, Fair and Handsome, and it's a mess. And some of them are adulterated with things that can bring about depigmentation, especially when you have things like hydroquinone, you have phenolic compounds, surfactants, which can bring about chemical leukoderma. Also, laser procedures like removing hair, they can also leave behind. So it's very essential to look for iatrogenic problems giving rise to a hypopigmented or a depigmented spots. So the OPD approach for a patch on the face, which is white in color, which I learned from my very good friend and the senior most pediatric dermatologist, Dr. Vijay Bhaskar, who would always stress on for a pediatrician, the best way to look at it is have a magnifying glass and plenty of light. And what we do in practice is we use the otoscope, which is used as a rhinoscope, which is used as a dermoscope, which is used as a trichoscope, a good quality otoscope through which you have a good source of light and a magnifying glass that will tell you whether the surface is scaling. That's number one. So when you look at the surface and you find scaling, the differentials are limited. This is basically what I usually see in practice. So it could be pityriasis alba, pityriasis versicolor, polymorphic light eruptions, seborrheic dermatitis. All these are scaling lesions. Whereas the non-scaling common lesions that we see in practice is vitiligo, post-inflammatory pigmentary problems, the nevus depigmentosus and nevus anemicus. In fact, the nevus anemicus is not a pigmentary problem. It is just the vessels which are vasoconstricted because they are hyperreactive to catecholamines, and there is no pigment dilution or a defect in the pigment distribution. And the Hansen's, which we can't forget. So what we require as a diagnostic help, you require the 3 L's. You require a good quality lens, you require the Wood's lamp, and you require adequate light. And if you have a super specialty OPD next to you, you may have a mexameter, which these are various types of meters which are now in the market, which will tell you the extent of pigmentation. They will tell you the extent of pigmentation and the contribution too. So by these meters, you will get to know the melanin contribution, the hemoglobin concentration, the carotenes contributing, the gloss of the skin, and even the sebum content. And these are used by the cosmetic industry now in a very big way. And they are extremely helpful when we have to differentiate between a hypopigmented and a depigmented lesion. The Wood's lamp is another thing which is of great use because in a light-skinned person, when you use the Wood's lamp, the disparity, I mean the change in the color is so evident that when you have a depigmented spot, it is porcelain white. And when you have a hypopigmented spot, it is just off-white. So in a fair-skinned person, to pick up a depigmented spot becomes extremely easy with a Wood's lamp. Also, when you have a fungus infection, the Wood's lamp can bring about fluorescence. So if you have a tinea versicolor, you may have a golden yellow or a greenish yellow fluorescence. That itself will pick up the pityriasis versicolor or tinea versicolor. And the light source is very important. And the lens are the most important thing because you're going to be looking at the surface. When you look at the surface, it's not just scaling. You're looking at the margin. If you have well-defined margins like tinea versicolor, which are coalescing with one another, you have pityriasis alba where there is where the margins just blend with the surrounding skin. Or you have a nevus depigmentosus. It's a wrong terminology. It is not depigmented at all. It's just that the distribution of melanin is a problem out there. And what you do see with a dermoscope, as we call it as, is a peripheral telangiectatic vessels and a little bit of dilutional color in the center. So a lens, a lamp, a light, and you also require a glass slide. So when you're thinking of a set of vessels which are hyperreactive catecholamines and they are responsible for the pale color or the white color, you press the slide and they come back to the original color with the surrounding. Your diagnosis is there that this is an apparent hypopigmentation and not a true hypopigmentation. And to top it all, you have a mexameter. Today, what we do is we have a dermoscope which is connected to a computer where you have an AI, which has an algorithm fitted to it. And you have to click a photograph and it gives you every possible thing. You have dermascopic attributes, which will tell you that this could be the following things. So just with a lamp, lens, light, you could come to a diagnosis. You need not get into further investigations in the form of a biopsy. So we Indians are very famous with jugaad. So when you have to use the woods lamp, you require a dark room. Now, who's got it's a luxury to have a room first and then to have a dark room. So this is one of the jugaads that has come in one of the Indian Journal of Venerology and Dermatology, where they connected a black cloth and switch off the lights. You can't make it totally dark, it's fine. And you peep in through this. A second way of going about a woods lamp could be use your smartphone to put it into the blue light and increase the brightness to maximum, and then assess these white spots, and you'll get to know that if they are absolutely porcelain white, it is depigmented, whereas if they are off-white or different shades of gray-white, you know it's a hypopigmented patch. So that is the first start that you get. And if you are in a super specialty clinic, yes, you are going to use all types of mexameters. And if it is depigmented, you know there is an accentuation, and you know when there is a fluorescence, it could be a tinea versicolor, it could be an erythrasma because of a Corynebacterium minucitism. And there are so many things that could bring about a color. And that's the beauty of the woods lamp. So here I've shown you two photographs. One is a depigmented lesion, that's a vitiligo. The other one is tinea versicolor, which is hypopigmented. Further discussion in the slides to come. So what I do with the woods lamp, when I look at these spots with a woods lamp, the first one is, like you can see, it's an ash leaf appearance. It's only a hypopigmented spot. It's not a depigmented spot. The second one is vitiligo, where you can see the porcelain white color. And the third one is a tinea versicolor, where the lesions are coalescing, and what you get is some amount of fluorescence on the woods lamp. So see the usefulness of a woods lamp. The only precaution is don't put this light on the eye. The eyes have to be closed. They are a problem as far as the eyes go. The second device that I spoke about is the lens. And the best among the lot would be what is known as a dermascopy. You have different powers of the lens. And in a dermascopy, the minimal being about 10. What we do see is the scaling that you can see so beautifully in the first slide on the top. And then the second one is where you have an atrophic skin. These are seen in conditions like lupus, which have healed with a depigmentation or hypopigmentation. And the last one is a vitiligo, where you can see again that there is a border of hyperpigmentation surrounding the porcelain white patch. And on the right side, what you're appreciating is the scaling, and the scaling along the skin lines. And that's very classically seen with pityriasis alba. So the one right on top is a classical feature of tinea versicolor. The second one is an atrophic one, which could be lichen sclerosis or lichen sclerosis atrophicus. The third one is a classical vitiligo, and the one on the right side is the scaling, which is usually seen in P. alba. So the dermascope has made it so simple. Also with a dermascope, you can see inflammation. So when you do see inflammation in a suspected case of P. alba, this is when you would use a very low potency steroid along with an emollient. And when you see infiltration, thickening, plaque formation, the absence of hair, you see all types of follicular abnormalities like pigtail, eccrine ducts being blocked, and you have a suspicion of Hansen's, the dermascopy is a corroborative evidence that yes, this could be leprosy. And we have charts like this, wherein we have all types of features that are shown. This is now incorporated by AI into a software. So when you connect your dermascope to the computer and you take a photograph, you get a nice report by the side giving you the possibility based on the findings that is picked up by the AI. You could also do what is known as scraping. So what we do is we scrape the border, scrape the surface, and we add a little bit of potassium hydroxide, and then we heat this up, and the KOH dissolves the keratin, and then you can appreciate the fungal elements, the hyphae and the spores. And if you get a picture like on the left side, this has been stained with a blue dye, because if you just have the KOH, it becomes a little bit difficult to appreciate the hyphae and the spores. But if you use any of the various blue dyes that are available, the cheapest and the easiest to procure is methylene blue. You can appreciate the spaghetti and meatball appearance or a bunch of grapes that's seen with Tinea versicolor. And biopsy is definitely required, especially when you have an infiltrative disorder like sarcoid or a leprosy, which brings about a so-called question mark, wherein you really need the intervention by a dermatologist. So let's look at white spots that are seen since birth. So the first one, what you appreciate here is you don't require even adequate light. It's so obvious. It has the base towards the scalp. There is white hair. So you have poliosis. You have a patch of depigmentation with islands of pigment. The eyelashes also are showing poliosis, that is depigmented hair follicles. Why I'm stressing on hair follicles, they are the reservoir of pigments. And this is a migrational disorder, piebaldism. And here you can have overlap syndromes, the various Waardenburg syndrome, in which my teacher has a name, the Waardenburg-Kahn Shah syndrome, wherein you have Hirschsprungs in association with these features. In addition, you can have iris abnormalities and deafness. The second one, wherein you are seeing this in the initial few months or in infancy, world pattern, a particular pattern following Blaschko lines. This is hypomelanosis of Ito, an old terminology. Now we call it as pigmentary mosaicism, and a number of conditions under this umbrella term. So this makes it very, very obvious. And these are pigmentary conditions wherein you need to look beyond the skin, where there is a lot of systemic involvement. Here, this child was referred for convulsions, for an assessment of the skin lesion that we saw, and we felt that this could be a hypopigmented lanceolate piece of this thing that was seen on the cheek as well as in the trunk. They were just 3 in number. This child had infantile spasm, and the suspicion of tuberous sclerosis was very high, and it was proven by genetic study and when we studied the other family members. So again, history is something very important, and you need to fit in everything when you look at a hypopigmented patch. So this is again right from birth. This is the earliest thing that we do see in tuberous sclerosis in the very first year of life. Then again, if you see something like this, which is very early in life, which becomes more prominent as the baby grows, but this particular hypopigmented patch remains the same. What I'm trying to say is the naksha remains the same. There is no change in the texture. There is no change in anything except in the size, because as you grow, it grows. It's almost like, this is a great saying by a dermatologist, Dr. Inamdar from Karnataka. Great admiration for him, who would always talk about, you draw a small circle on a deflated balloon and start blowing the balloon. And as the balloon becomes big, the size of the so-called circle also starts becoming big appropriate to the size of the balloon. The same thing happens with nevus depigmentosis. This looks like a splash of paint, and when you look at it, you know this is hypopigmented rather than depigmented, extremely stable. But there are some association with other conditions, and this is not a problem at all. This is nevus anemicus. I told you it's not truly a pigmentary problem. You apply a slide and apply pressure, what is known as diascopy. It merges with the surrounding, but when you use the dermascope, you will appreciate the pale areas surrounded by telangiectatic areas, and that the vessels out here are a little bit hyperreactive to the catecholamines in the body, and that's why the color change. And they may require a little bit of camouflage, which could be in the form of cosmetics or other cosmetic procedures that are being done nowadays. So that was the difference between a nevus depigmentosus at the bottom one and the nevus anemicus on the top. And what is shown on the right side, the two ones are the dermascopic appearance. The left one is the depigmentosus, and the right one with the telangiectatic vessels in the periphery is nevus anemicus. Now let's go to the white spot. Here, the patient had pigment and has now lost it. Again, you require the lamp, the lens, the tricks, the association, and the mistakes that we make. So when you look at this child, this is the commonest that we see in our OPD practice. So I had this grandmother who came and told me, Doctor, ये बादाम की वजह से तो नहीं हुआ. And I was thinking why the badam should cause this. And she was giving this little kid a lot of badam because she wanted fairness and she wanted a lot of the IQ levels to go up. And this child had severe allergy in the form of repeated wheezing attacks and a running nose and atopic family. The infraorbital crease had a crack, and everything was pointing towards an atopic diathesis in this child. And looking at this, you can make out that the border is not well defined. It's blending into the surroundings. The surface is definitely scaly. And you do know that there is a simple trick. Again, this is called the Inamdar trick, wherein you tell the patient to go and wash his face with soap and water. And when he comes back, you can see that this becomes more prominent, because this is almost like a post-inflammatory hypopigmentation. It's basically a dry skin, and when you make the dryness more by applying soap and removing whatever little oil is there, it becomes more prominent. Also, the prominence becomes, they become more prominent when there is more sun exposure, because the surrounding areas get more tan than the affected areas. And you need to know that when you do a dermoscopy and you don't find any inflammation, there could be a little bit of mild itch. There is no need to use steroids. All that you require is emollients, and a liberal amount of emollients, and they do very well, and a lot of reassurance. And the mistake that we all tend to do is know all about your steroids, know what is potent and know what is very potent. Never make a mistake of using any form of potent steroids on the face. You tend to cause thinning, you tend to cause hypopigmentation, you tend to cause telangiectatic vessels coming into prominence, and the repair work is extremely difficult. Again, here is a child, and what tells you this is seborrheic dermatitis with secondary hypopigmentation is the seborrheic areas and a little bit of the flakes of dandruff that are seen on the top. And seborrheic dermatitis is something that comes up like this. And again, you treat the seborrheic dermatitis. There is an association with the commensal in the skin, malassezia, which loves oil. And again, it's just one of the many contributors. But if you have persistent seborrheic dermatitis, you need to look for immunodeficiencies right up to HIV. This is something that we see left, right, and center in our OPD. And nowadays, the teaching used to be in the olden days that this is something which is seen post-pubertal when there is an androgenic spurt and you get a lot of sebaceous secretion. But now we are seeing it even in the neonatal period, in the infantile period, because of so much of application of oils. And what is very obvious in this is they have a nice border. And the trick out here is you tend to stretch it and the scales become much more prominent, what is known as the evoke sign. Or you take a tissue paper, moisten it, and rub it on it, and you can get the tissue flakes on the tissue paper, which look a little bit dirty and yellowish. And when you put the Woods lamp before washing the face, you could get the yellowish green or the golden yellow fluorescence of the pityriasis versicolor. It's called versicolor because you can have light color as well as dark colored ones. And what is to be understood out here is you can't get the color back with treatment. It takes a lot of time. What you can do is you need to understand that it's an abnormal proliferation of malassezia, which has changed from furfur to globosa to so many other new entities. And they produce multiple products. One of them is azelaic acid, which is responsible for the hypopigmentation. And once you treat it, for the color to come back takes a lot of time. And it's very essential for you to convey this to the patient, and you may have to continue treatment for a definitely long period of time. Another presentation again of the same thing, tinea versicolor. And what is very important for you to understand is when you look at a skin disorder, people panic because they feel it is contagious. This is not contagious. It's an overgrowth of your commensal, and you need to control the overgrowth of the commensal. And I always feel it is better to have local application rather than giving oral antifungals, because what is reachable directly and you're trying to give something by the mouth that gets into your intestine, then your liver, and then into your bloodstream, and then it creates a reservoir in your skin. That's absolutely stupid, because all these azole drugs like fluconazole, itraconazole, all of them have a dangerous side effect, that is they can prolong the QT interval, and they are all the cytochrome P3450 inhibitor. 40% of the drugs that we take are through this cytochrome system. So it's always better to use something locally rather than to take something by mouth for this particular thing. Still again, this is in infancy, we have picked it up. See, the distribution behind the ear is what clinches it. And again, the scaling towards the periphery. And here you have the two slides. The first one, which is just an oil immersion with potassium hydroxide, wherein you appreciate the spaghetti meatball, which is better appreciated when you put the blue stain. And the third one is under the Woods lamp, the fluorescence, which is not very well appreciated, but most of the photographs have been taken from the net because I needed some sort of continuity so that we could understand what we were going through. Looking at the first slide, all of us would know that this is probably vitiligo. What clinches the diagnosis is first confirm that this is porcelain white, depigmented. So use a Woods lamp and see the accentuation of the white patch. It's amazing. Second, look at the eyebrows. The moment you get poliosis, that is white eyelashes, you know for sure that the pigment deposit or the pigment storage in the hair follicles is lost. You know there is an autoimmune process going on, and you know for sure, yes, 90% it is towards the vitiligo. Then what you try to do is you look at other places in the body, and if you start finding at sites of trauma, you start finding white patches. Yes, again, it goes in favor of vitiligo. These are pointers to vitiligo. And if you find the third photograph that I put here, the small one, which is a halo nevus. So you have a dark center with a depigmented or a hypopigmented going into depigmented surrounding it. And if you find more than one, it definitely tells you, yes, there is an immune process that is going on. There is an aberrant immune process wherein you're losing your melanocytes. You don't know the trigger, but you know for sure this is happening. Now, when you look at vitiligo, you can have segmental one side, you can have universal, you can have peri, like around the eyes, around the nose, around the lips, around the genitals, around the anal orifice. You can have it the lip tip variety, you can have a universalis, you can have a vulgaris. There are so many types. The one in the pediatric age group, which progresses like the segmental one, and it stops also very fast, and the prognosis also many times is excellent. So I think you find anything of this sort, it's always prudent for us, because most of the medications that we are going to use on this particular area, like steroids, the calcium urine inhibitors, the oral newer agents, you require somebody with a lot of experience. It is always prudent to refer this to the dermatologist. What I've also mentioned in my slide is if there is a history of alopecia areata, a thyroid, autoimmune thyroid problem, or there is a familial history, or you find these white hair, yes, they may all point towards vitiligo. Depigmented, what clinches is the hair, the reservoir for pigment. So when you have something of this sort, yes, don't make a mistake, don't waste time, better to refer to a dermatologist who can do the best as far as this condition is concerned. This is where you need to think out of the box. So here is a child which requires good history. And you are totally in a fix because this doesn't fit the usual run the mill. And there is a patch, a plaque, it's elevated, looks infiltrated on the dermascope, and you're not able to make out what actually it is, though the pigment distribution is much less than the surrounding, and there is no hypostasia, and you can't find any thickened nerves around. What you tend to do is you have to think of everything out here. And when you find an index case in the family, why is it that you don't get anesthesia? Because the face has a terrific innervation, nervous innervation. So there is so much of overlap, you may not pick it up, you may not have the discrepancy in hot and cold, but you may get classical dermoscopic findings like hair follicle abnormalities, pigtail, follicular openings being defunct, eccrine openings being blocked, infiltrated skin. In addition to, you make this child stand in the sun, you may find this patch may not sweat. So you have to think out of the box when you're thinking in terms of itch or leprosy. And when you have an index case, straight it goes to the dermatologist for further workup. This, again, you require a good history. So the first one, which is around the lips, here is a patient, when you take a history, you get to know he had a lip smacking dermatitis, for which he was using a masala cream, and he did pretty well. The masala cream also had multiple ingredients, including a metronidazole, to prevent him from licking. And what has now happened is it's a post-inflammatory pigmentary dilution, as well as it could be a drug-induced hypopigmentation also, because when you check these masala creams, they all have some potent steroids like beclomethasone. So you need to look into what medications were used and the contents. Come to the right side, a fairness cream used by this girl who's 16. What you can see is fine hair growth. You can see telangiectasia and thinning of the skin, and see the patches of hypopigmentation here and there. These are all steroid effects. So you need to ask for medications used, and you need to give a lot of importance to history when you're looking at these conditions. This is again funny. So this is an adult. It's an instructor. He's a swimming teacher. And he wanted an opinion of my friend whose kid was going to the swimming pool, and he happened to send it to me. And he said, "You do a lot of dermatological clinics. What is this?" And I said, "This is definitely depigmented, and the distribution doesn't fit into everything. Just ask him if he's been applying anything and what is his profession." And he said that he also had a similar type of lesion on both around the ankles, and now it's around his eyes. And what we did find out that he was being, it was basically chemical leukoderma from the rubber goggles that he was wearing for swimming, and the sandals that he was wearing was also responsible for the chemical leukoderma on his feet. So chemicals can give rise to a vitiligo. This is a child who had a complete heart block at birth, and had erythematous and erythematous patches, which were macular. And this is right from birth. And the mother was a known case of SLE, and she was positive for both the Rho and the La autoantibodies. And this was nothing but a neonatal lupus with secondary hypopigmentation. The thrombocytopenia and the hepatic enzymes, which are deranged, rectified. But this took a very long time for the color to come back, and the cardiac condition requires long-term therapeutics. This is something that we are seeing nowadays, polymorphic light eruptions. Here, the history is very important. Acute exposure to sunlight, it starts off with itch and burning. You have a lot of redness, and as it progresses, you get these patches, which are classically hypopigmented with dark centers, variegated centers. And here you require a lot of photo protection. So what is very essential is a lot of photo protection. And again, see, this is a fair-skinned person with a white patch. You start thinking, what am I dealing with? This is where the Woods lamp would come into play, but this is in the periphery, and my friend had no access to anything except for adequate light. And he sent me this photograph, and he wanted to know what this could be. I told him, the moment you see the white eyelashes, scoliosis, it all points towards vitiligo, and that you should make a referral to the pediatric dermatologist. It was done, and this child is under treatment. Again, what clinched the diagnosis in this case, which was the thing on the posterior part, the part behind the ear, was what clinched the issue in this 2-year-old child who had well circumscribed, but the border was so distinct, again from the periphery where they didn't have much access to diagnostics. And he didn't get anything with my tricks of using a tissue paper which was wet. He couldn't get anything on it. But what clinched it is the one towards the hairline where you can see this coalescing with each other. And this child had a lot of oil application. And we are seeing a lot of problems with oil application nowadays. When I talk about skin, I always put this in my presentation because you need to understand that even though we talk about therapeutics, there are so many factors playing a role. So this is something that was sent to me by my cousin, who wrote that I'm losing hair. And as per your suggestion, I went and met the dermatologist who had this on his boat, get the glow back and the shine on your hair. I just wanted my hair back. And he prescribed a soap and oil, a shampoo, a conditioner. He gave me a minoxidil spray. He gave me multivitamins, which were perfect for my hair. He added a high-dose biotin. He gave me a chromium extract plus a herbal extract. And it was not just the consultation, but a long list of medications. And he also asked me to use a lot of almond oil that would also improve many more things in my system. And then as I walked out of his clinic, I see this beggar who was seated outside his clinic. He had no access to food, no access to soap, no access to shampoo. And when I look at his hair, I was surprised. Do I require all this? What is responsible? So it's all multifactorial. You need to understand when you're doing anything. So you need to understand it's a big eye when you see a white spot. It could be an infection, it could be iatrogenic, it could be immune, it could be irritation, it could be inflammation, it could be itch. And the biggest among all the eyes is I don't know. When this happens, take a second opinion, refer to the dermatologist. The common ones that we do see in practice is pityriasis alba, versicolor, the post-inflammatory hypopigmentation, vitiligo, the iatrogenic is coming right in front. We have had white patches because methylphenidate patches, chloroquine causing white patches, the newer inhibitors like the JAK inhibitors causing, and there are so many new biologicals and things giving rise to white patches, chemicals and cosmetics. And we have now algorithms. You can take down these algorithms, you can take down these photographs, asking the people from the scientific committee to share it with you, that when you have a localized depigmentation or hypopigmentation, how do you go about it? And you also have something to do with the dermascope. And when you have a dermascopy with you, how do you differentiate one from the other? So these two things you can click, and I'll give you a minute for this as well as a minute for this. And you can, in case you miss out on that, you can ask the scientific committee to share the slides with you. Thank you so much for a patient hearing. I hope I didn't exceed the time. Thank you, Sagar. Thank you, Sanjeev. Thank you, Vela. Thank you, Sachin, for tolerating. Thank you so much.
Thank you, sir, for excellent lecture, the excellent talk today on the white spot. You explained about the mixometer, how to use the Woods lamp, dermatoscopy. I think so. Most of the doubts which we had been cleared. And if any questions are there, please put the questions on the chat box. For the lack of time, we move ahead for the next lecture. I request Dr. Mankar sir to proceed for the lecture. Dr. Sanjay Mankar sir. He will be speaking on common pediatric skin infections.
Yes. Are my slides visible?
Yes, sir.
Yeah. So is it okay?
Yes, sir.
Yeah. Okay. So good evening to all of you. First, I would like to thank MahaIP for the invite. President Dr. Sanjeev Joshi, Dr. Sagar, then Dr. Sachin Patil sir, and Dr. Vela Verma madam for the invite. And I, of course, thanks Dr. Sridhar Ganpati, who has made my job very easy by excellent approach, how to examine the dermatological condition and how to diagnose it and how to make it very simple. So thanks, Dr. Sridhar, for this thing. So we begin as 15% to 20% of our OPD patients may have dermatological lesions, and these dermatological lesions, most of them are the skin infections, especially if you are practicing in a rural area. And these may be either bacterial, viral, fungal, or a parasitic infections. So a correct knowledge about all these infections is extremely important. This is not going forward. Just 1 minute. So slides are visible? Hello?
Yes, sir. Yes, sir.
Slides are visible. Okay, fine. So as Dr. Bela has already said, the scabies are very difficult to diagnose. Sometimes the residents are unable to diagnose. That's why, because we are not seeing that many cases or what. So this is the 3-month-old child has presented with multiple papular lesions all over the body, and they are erythematous. And when we ask a detailed history to the mother has also had a similar papular lesion, and you can see the involvement of the scalp over here. You can see the involvement of the breast area, umbilical area, and everywhere the lesions are there. There are hyperpigmented lesions at the few places. And he was treated with the multiple type of antibiotics and a cream, calamine lotion, and steroidal lotion. And when we just ask the history, and that's the importance of asking history very well. So we come to know that this is a scabies, and we treated with the anti-scabitic drug, and the child became all right. So the scabies are intensely pruritic lesions which commonly occur. So papular pruritic lesions which commonly occur more on either groin area, genital area, web spaces, axilla, below the breast. So this is the papular lesions which can occur as a scabies with the slight hyperpigmented lesions. So they are all scabies. The scabies in adults do involve the web spaces and all, but in the pediatric age group, the scabies commonly involve scalp, they commonly involve palms and soles, and the lesions not only papular, but sometimes they may be a vesicular lesions also, and they may be present everywhere on the body, including the face, palms and soles. So the classical palm sole involvement is also common in scabies. they are likely to get secondarily infected. So secondary infection is common with them. You can see the infection getting in occurring in the scabies. So they need a proper treatment with antibiotic first and followed by antiscabitic. So the scabies are known to cause eczematization, and the misdiagnosis can occur when they are already treated with the steroidal cream. So this is the scabies which cause eczematization, and scabies may present to you as a nodular lesion. These nodular lesions are common on the genital area as well as the axillary area, and these are very difficult to treat with the antiscabitic. They require intralesional steroids for the treatment. So these are very extensive scabies, may require oral treatment with ivermectin. So the differential diagnosis of the scabies consists of when they are eczematous lesion, it can be it may be confused with either atopic dermatitis or a seborrheic dermatitis. A papillary lesions may be confused with a papillary urticaria or a folliculitis sometimes, and a vesicular lesion with a dermatitis herpetiformis and a drug eruptions, while the nodular scabies may be confused with the urticaria pigmentosa and Langerhans cells histiocytosis. It's very important to treat them. As a family, you have to treat all the family members. A care of clothes is extremely important. You have to wash them very properly and iron them. For all practical purpose, the treatment of choice is permethrin cream 5%. It has to be applied over there for 8 to 12 hours and can be repeated after 7 days. Gamma benzene hexachloride is to be applied below the neck only after the age of 6 years, but has a neurotoxicity, so you have to be very careful in applying. So has to be applied above the age of 6 years only. 10% crotometan has a promising result, but it is a less scabicidal as compared to permethrin. A single oral dose of ivermectin 200 micrograms per kg is preferred when the scabies are resistant to the routine line of management. The dose can be repeated after the 7 days. A sulfur ointment 5 to 10% cream can be also used in the treatment of scabies. So when you see this kind of lesion, it is nothing but a pediculosis. It is very difficult to see a lice, but you are able to see the needs. They come to you as a intensely pruritic lesions on a scalp, and the intense pruritus can cause secondary bacterial infection and a lymphadenopathy. The child may come to you with the EID eruptions, that is erythematous papular or plaque-like lesions all over the body, especially on the trunks, which are allergic reactions called as a EID dermatitis. So this pediculosis commonly gets transferred from person to person or by sharing towels or combs. The treatment is for all practical purpose. The lotion which is available currently is a permethrin lotion, which is used 1% permethrin lotion. It has to be used after shampooing and drying the hairs. It has to be left there for 10 to 15 minutes and then rinse off. Recurrent cases and non-responding cases can be treated with ivermectin, similar dose 200 micrograms per kg, a single dose, or may be repeated after 7 days. And a malathion or a linden lotion is used above the age of 6 years, which has to be used on a dry scalp and to be left there for around 8 to 12 hours, and then the hairs are shampooed. So that's the typical pediculosis. When you see this kind of child with a honey colored or a golden yellow crust, it is nothing but impetigo. It's a very common lesion in your clinical practice, and impetigo can be either a non-bullous impetigo or a bullous impetigo. The commonest cause of non-bullous impetigo is, of course, a Staph aureus and sometimes by the streptococci, while the bullous impetigo is always caused by Staph aureus. As you can see, the flaxseed bulla, which are there on erythematous base, which are filled with the pus fluid. So they are classical bullous impetigo and always caused by Staph aureus. It is the bullous impetigo and non-bullous impetigo are better to treat because they can cause local cellulitis, they can cause lymphadenitis, and sometimes they may lead to acute glomerulonephritis, post-streptococcal glomerulonephritis, or rarely they can cause complications like osteomyelitis, septic arthritis, or even they can cause pneumonia and other invasive diseases. So when you see such kind of a bull impetigo, when the lesions are less than 5 in number and minor, they can be treated with the topical antibiotics like fusidic acid or mupirocin. For the practical purpose, the mupirocin is a drug of choice. But the resistant cases, ozenoxacin is a preferred drug. Ozenoxacin has a better MRSA coverage. But when the child has a multiple lesions, they do not respond to the topical application. And as shown in the picture, the child has a lesions on a face where the ointments can be licked away. Or when the child has a impetigo in a dangerous area, it is better to treat with a systemic antibiotics, and drug of choice is first generation cephalosporin like cephalexin or cefadroxil for 5 to 7 days. When MRSA is there, then either trimethoprim sulfamethoxazole combination, that is Septran, or clindamycin, and above age of 8 years, doxycycline can be used to treat multiple impetigo. So these are the extensive impetigo which requires a systemic antibiotic therapy. After removal of the crust, these crusts are very important. They have to be removed, and then only the antibiotic creams will be helpful. So these are the extent. This is nothing but ichthyma. Ichthyma is a chronic and deep form of the impetigo, which initially resembles like non-bullous impetigo, but it is a deeper and chronic form of a skin infection. The commonest organism is again Staph aureus or a streptococci. They start initially as a small vesicular or a pustular lesion on an erythematous base, which breaks down to form a ulcer with the elevated margin, and later on there will be a formation of crust, and these crusts later on heal with scarring. So scarring is an important feature because this is a deep form. Most of these ichthyma are treated with the same line as either with the cephalexin or a cefadroxil. But when this kind of a lesion occur, especially in the immunocompromised host, these are called as ichthyma gangrenosum. The ichthyma gangrenosum begins with the same vesicular lesion, but these ulcers lit with the black scar over there and black this thing. So you can see these are the ichthyma gangrenosum. The commonest organism behind ichthyma gangrenosum is Pseudomonas, but it may occur with the others like other gram-negative organisms, including E. coli, Burkholderia, or sometimes fungus like Candida and Aspergillosis. They are more common in an immunocompromised individual, and neutropenia is a single most risk factor. And you can see this child who is a case of acute lymphoblastic leukemia suffering from ichthyma gangrenosum. This is a 3-year-old child coming to with a, can see a vesicular lesion occurring on index finger. So that's the classical blistering distal dactylitis. The blistering distal dactylitis is an infection of the fingertips, and it is commonly occur because of the streptococci and staph infection. It may lead to paronychia, and you need to incise them and treat them with either cephalexin or with amoxiclav for 7 to 10 days. So this is child with classical staphylococcal scalded skin syndrome. It is common in pediatric age group less than 5 years because of the failure of the kidney to excrete the toxin. This staphylococcal toxin is responsible for this kind of lesion. The child commonly comes to you with the fever, mild fever, the redness of the skin, tenderness of the skin, and the skin appears wrinkled, and there are always peri-orificial lesion. So the orifices may be, so you can see the around oral cavity, around the nose, around the eyes, the lesions occur in a wrinkled fashion and radiating away from the cavities. So they are classical lesions of staphylococcal scalded skin syndrome. They may begin as a small bullous lesion, and later on it can, when you see the child, you may have a positive Nikolsky sign along with this. So the Nikolsky sign, you apply a lesion, a small pressure on the skin and make it, so just slide the skin and the skin will come out. So this is classical Nikolsky sign, which you can see, and that's why this, you can see this lot of scalding occurring over here. So staphylococcal scalded skin syndrome presenting with this. So the treatment of the staphylococcal scalded syndrome is emollient, care of hydration and electrolyte balance. The child may require hospitalization if it is a severe, and prompt antibiotics. When the disease is mild, you can manage it on OPD basis with oral cephalexin or oral cloxacillin. But when it is a moderate, it is better to hospitalize the child, start IV fluid, take care of water, electrolyte balance and nutrition, and also start with IV cloxacillin or clindamycin. When MRSA is suspected, it is better to give vancomycin or linezolid for the period of 7 to 10 days. So multiple papular dome-shaped lesions on erythematous base is nothing but folliculitis, which is common in a hot weather, and the child who is sweating a lot, especially in an area where the hair follicles are common. So the folliculitis, the commonest organism is again a Staph aureus, but can be caused by streptococci. It has to be differentiated from Candida. Treatment is mainly with the clindamycin lotion or mupirocin or ozenoxacin cream. Sometimes it may be severe and extensive and may require a systemic antibiotic therapy with either cephalexin or cloxacillin. Folliculitis can be very extensive when the child has either diabetes mellitus or immunocompromised individual. So this is classical, what we call it as a perianal infectious dermatitis or streptococcal infectious dermatitis. The child commonly presents to you with difficulty in passing stool, pain while passing stool. They present as erythematous, reddish, velvety, moist lesions around the anus, radiating from the anus outward, and they are sometimes tended to touch, but constitutional symptoms like fever and all are not there. When this child was gram stain was done, showed a gram positive cocci. So this is classical perianal infectious dermatitis and treated with the oral cefuroxime for 10 days and with the local application of mupirocin ointment. This is much more severe form of skin infection, which is the deeper and severe form called as a necrotizing fasciitis. And all constitutional symptoms, fever and pain and tenderness, is disproportionate to the cutaneous. So you can see the edema extending beyond the cutaneous involvement. The child has extreme high-grade fever, tachycardia, and all these features. So this is typical necrotizing fasciitis. And there are multiple types. The type 1 may be a polymicrobial. The type 2 and type 2 may be associated with only streptococcal infection and toxic shock syndrome, and type 3 in immunocompromised individual with gram negative as well as sometimes with the fungal element. So necrotizing fasciitis requires very prompt treatment. This prompt treatment consists of a surgical debridement, which may be require recurrent antibiotics, mainly intravenous antibiotics, either ceftriaxone with clindamycin or vancomycin, piperacillin tazobactam plus vancomycin or linezolid or daptomycin also, or in severe cases either meropenem plus vancomycin or linezolid or daptomycin is a drug of choice. This is classical pityriasis versicolor, already covered by Dr. Sridhar Ganpati very well. So these are a hypopigmented macular lesion with fine scales. And he has already said how the Woods lamp will be helpful, showing the when you do a Woods lamp examination, it will show golden yellow fluorescence. And when you do a KOH mount, it will show fungal hyphae, and it may show a spaghetti meatball appearance or a grape-like appearance, as Dr. Ganpati has already covered. And very important, these when exposed to sun, these areas will not tan. So versicolor means variety of colors. In dark individual, it will be hypopigmented or hyperpigmented, and in a fair individual, it may look like a pink or a brownish color, whitish patches or with the scales. So the treatment of this pityriasis versicolor consists of topical application. The topical application of selenium sulfide shampoo 2%, which is diluted and applied over there for 10 minutes. It is left over there and daily for around 1 week. Same ketoconazole shampoo can be applied for 10 minutes and daily for 1 week. A terbinafine spray twice a day for 1 to 2 weeks, and sometimes even either clotrimazole, miconazole, all this cream may work, but it is impracticable to apply this cream all over the body. So it is better to apply these. Last, systemic therapy may be required when they are very extensive and not responding to the topical therapy. Either oral fluconazole 6 milligram per kg once a week for 3 to 4 days, or itraconazole 5 milligram per kg per day for 1 week is a preferred drug of choice for treating tinea versicolor. Classical lesions of tinea corporis presenting as a plaque lesion with central clearance and peripherally spreading margins. Classical tinea corporis. The treatment of the tinea corporis, they are mainly caused by dermatophytes like tinea rubrum and tinea montagiphytes. Topical antifungal creams which are useful are either clotrimazole, miconazole, luliconazole, ketoconazole. Anything can be used for the period of 3 to 4 weeks. Terbinafine cream can be used for 2 to 4 weeks. It is very important to know that you have to apply the cream beyond the margins. So you have to apply the cream beyond the margins and not only over here. Otherwise, the fungus will go on spreading. So you have to apply the cream beyond the margins. Severe and extensive diseases should be treated with oral griseofulvin for the period of 4 weeks, or terbinafine or itraconazole for the period of 2 weeks. The classical tinea cruris, beginning as elevated plaque lesion beginning on the one side of the inner aspect of thigh, gradually going on spreading in the groin area. So this looks like a ears of elephant. That's why it is called as Gajakarna in Marathi. Marathi Gajakarna mantat, looks like a elephant ears. So the treatment of this is same. You have to treat with either, most of the time they vanish with the application of the antifungal creams. Typical candidial intertrigo. The child begins this candidial intertrigo common in the neck area, axillary area, groin area, buttock area, or in a obese children, pendulous abdomen just below the body folds, they can occur. So classical candidiasis, they begin as sometimes small vesicular lesion or a moist lesion over here, and they can be confused with a bacterial infection. The classical lesions with lot of satellite lesion is a hallmark of candidiasis, candidial intertrigo. You can, the treatment of the candidial intertrigo is same. You have to apply the antifungal cream for the period of 2 to 3 weeks. When resistant treatment, you can use oral fluconazole. A classical candidial diaper rash classically begins as a small vesicular lesions or a papillary lesions and going on spreading. The satellite lesion is a hallmark of this candidial diaper rash. The involvement of the body fold, involvement of the groin fold is a hallmark where candidiasis involves this fold, while the diaper rash will not involve these body folds. Most of them can be managed with only antifungal creams. Don't use steroid cream, don't use masala creams, as Sridhar has already said. Only topical antifungal cream is a treatment of choice for treating candidiasis. In very severe cases, when a lot of inflammation is there, a separate antifungal cream along with mild steroid like a desonide, which is used for just 4 to 5 days where the inflammation subsides, or clobetasol 17 butyrate you can use, and continue antifungal cream and stop steroidal cream. Recurrent cases, severe cases can be treated with oral fluconazole. The child presenting with the multiple abscess and treated with the multiple antibiotic, no improvement at all, is nothing but a carry-on or fungal infection of the scalp. The fungal infection of the scalp commonly present as a loss of hairs, scarring alopecia is a common. Fever may be there, lymphadenopathy may be there, and the child doesn't respond to oral or topical antibiotic cream. You can diagnose this by KOH mount. It will show hyphae, fungal hyphae. So this is classical carry-on presenting as a boggy lesions because of the immunological reaction to the fungus. So the classical immunological reaction, boggy, and you can see the abscesses. They are not very tender. If it is only a bacterial infection, they are tender. The treatment is mainly oral. Here, creams and lotions will not be helpful. It is always oral antifungal like a griseofulvin, 10 to 15 milligram per kg per day for the period of 6 weeks, or sometimes you may require for 6 to 8 weeks. Itraconazole 5 milligram per kg per day for the period of again 6 weeks, and terbinafine 3 to 5 milligram per kg per day for the period of 3 to 6 weeks is a preferred treatment. A fungal infection of the nail commonly begins, it is commonly caused by either T. rubrum or T. montegrophytes. When it occurs, initially it may look as a superficial lesions on nail bed as a whitish lesions, but later on the nails become yellowish in color, they become thickened, and later on they may become brownish in color, may become brittle and fall away. So it's better to treat early. You can diagnose them, scrape the nail and stain it with the KOH mount. You will be able to find out the fungus. The treatment is of course systemic antifungal like itraconazole for the period of 3 to 4 months or terbinafine for the period of 3 months. Topical antifungal agents are useful only for very superficial mild cases, and especially in children you can use this. Cyclopyrox is one of the drug, or efinaconazole is another drug which can be used for the treatment of the systemic antifungal agent. A classical hand-foot-mouth disease presenting as a vesicular lesion. The common lesions will be there on knee, buttocks, perianal area. They will be on palms, soles, and oral cavity. Nowadays, you can see the multiple lesions everywhere on the body. They are commonly caused by Coxsackie A16, but when they occur with the Coxsackie A71, where A6 lesions tend to be generalized and severe. With Coxsackie A71, the lesions may cause sometimes, rarely, encephalitis, pulmonary edema, or myocarditis are the complications which can occur. This commonly hand-foot-mouth disease is a self-limiting, does not require much treatment, but when it gets complicated, you may require a treatment. They have no role of antiviral agents like Acyclovir should not be misused in these conditions. When it is very severe, you may have to choose IVIG when it causes the complications. Classical herpes labialis beginning as a small vesicular lesion. When they are restricted in one area, you can use topical acyclovir ointment, but when it is a severe ulcerating, you may have to use oral acyclovir for treatment. Classical herpetic gingival stomatitis. This is a very painful condition. The child begins as a vesicular lesions which gradually spreads on. There is child has a difficulty in opening the mouth, drooling of saliva, difficulty in swallowing. There is lot of gingival swelling, and this child requires hospitalization because they are unable to swallow anything, IV fluids, and you may have to give IV acyclovir for 5 to 7 days. So this is a classical herpetic whitlow. This is common in child who has a habit of thumb sucking. They present as a painful vesicular lesions on either thumb or fingertips where the finger is licked. The child has a subclinical herpes simplex infection and he acquires that infection. It is very important not to incise these lesions as incision may prolong the recovery. So it is important to treat them with oral acyclovir for 10 days. And you can use topical acyclovir also. So classical chickenpox, crops of lesion occurring in the same child, multiple stages of the rash, that is papule, vesicle, erythematous base. You can see central umbilication. So classical chickenpox, most of the time chickenpox are the self-limiting and you don't have to give acyclovir to all the kids. The acyclovir is indicated for any child in neonates especially and less than 1 year infants. It is also indicated for about 10 years of age, and in 1 year to 10 years, those who are immunocompromised, those who are having chronic cutaneous problems, those who are having chronic pulmonary problems, those who are on aspirin therapy and steroid therapy may require oral acyclovir. But when chickenpox occur in an immunocompromised individual, they tend to very severe. You can see this hemorrhagic chickenpox, and the child gets a pneumonia alba along with this and requires hospitalization and ICU care, and IV acyclovir is a drug of choice. Classical herpes zoster dermatomal distribution of the vesicular lesion begins with extreme pruritus as well as extreme burning sensation. The complications like post-herpetic neuralgia are not common. They are not common in pediatric age group, but it is better to treat these zoster lesions with oral acyclovir for the period of 5 to 7 days. The Shingrix vaccine is available to prevent herpes zoster only above the age of 50 years. So it is not recommended for the pediatric age group. Classical herpes zoster involving face. So here the chances of ophthalmic involvement is high and the chances of cornea getting damaged is high. So better to treat as early as possible with oral acyclovir. So the classical lesions of condyloma acuminata, the adolescent boy presenting with a fleshy, moist lesion. These lesions go on increasing to form a cauliflower mass. They are caused by human papillomavirus HPV 6 and 11, and it's a preventable disease with the vaccine. And the treatment of choice is application of 25% podophyllin on the lesion, and they regress very fast with the 25% podophyllin application. Classical molluscum contagiosum, they begin as a pearl dome-shaped lesions, common everywhere, but they are more common on the face. They are more common on the genital area and spread very rapidly. The treatment, they are most of the times very self-limiting and require a lot of counseling. Manual removal can be done if they are small in number with the help of needle. TC applicant, trichloroacetic acid application can be done, but don't apply on face as it causes scarring. Cryotherapy can be used as with the liquid nitrogen. Imiquimod is a cream which can be applied. Immunotherapy with the help of Candida antigen can be done. These are the classical verrucous lesion present on the face, forehead, and you can see a Koebner phenomenon occurring, the classical lesions of verruca plana. So these are the warts which are commonly caused by type 2 and type 4 HPV virus, verruca plana. Plantar and Palmer warts are also common, caused by type 1 and type 10. So these are painful warts which occurs. The treatment of the warts consists of daily application of salicylic acid or a liquid nitrogen cryotherapy or laser therapy, or when the lesions are very severe and not responding, you can use oral cimetidine 30 to 40 milligram per kg per day, and immunotherapy with Candida or dermatophyte antigen is also preferred. Dr. Sridhar has also covered this, so I will be going very fast in this. This is a 7-year-old child presenting with hypopigmented plaque lesion on the face with the satellite lesion, and you can also see another lesion over here, which is edematous lesion, and you can see. So when this child was examined, a detailed history was taken and the child was examined in detail. The child also had great auricular nerve thickening, and there was loss of sensations and loss of sweating from this area. And so the child's biopsy was done, which showed Hansen's disease. So this was classical child with the Hansen's disease, but in pediatric age group, most of the time it may be a paucibacillary disease. So the skin clip was negative and this child was diagnosed as tuberculoid form of leprosy with type 1 reaction. And the paucibacillary leprosy is treated with the help of dapsone 1 milligram per kg per day for the period of 12 months, and along with the rifampicin once a month. And multibacillary is treated with the dapsone, rifampicin, and clofazimine. And this is how the child recovered after complete therapy. So last slide, a 5-year-old girl presenting with this kind of a lesion on the nose, typical apple jelly nodule appearance of the lesion, apple jelly nodule. When the biopsied, it showed classical tubercular granuloma. So this is apple jelly nodule is a hallmark of lupus vulgaris lesion initially. So later on it may go on spreading to form various ulcers, and these ulcers can cause this kind of scarring in this. And so this is classical lupus vulgaris. So I stop here for your, and thank you very much for the patience hearing. Thank you very much.
Thank you, sir. Thank you, sir, for highlighting all the cases, right from what you see in the OPD and what we see in the when we admit the patient, right from hand, foot, mouth disease, herpes simplex, herpes zoster. You highlighted upon impetigo, staphylococcal scalded syndrome, necrotizing fasciitis, then tinea vesicular, carry-on. All the topics which we have routinely in the OPD practice also, and which we the cases which are admitted also. Any questions? Any questions? Please type in the chat box.
I think there are no questions. Actually, every slide and everything is well explained by our experts. And it is one of the most common entity in our day-to-day OPD practice.
If there are no questions, I thank Dr. Ganpati sir and Dr. Sanjay Mankar sir for their excellent presentation and for taking out time from their busy practice. And I thank all the audience who joined for the today's session. Thank you.
I think I would like to appreciate both the speakers for one important thing in their presentation. None of their slide had more than 5 to 6 lines. So for the young presenter, this is a good learning curve that how to make the PPT. the PPT should not have more than 6 lines maximum. Sometimes, if at all you have a pictorial presentation, it is well taken by the audience, and so I really congratulate both the speakers for that. And each slide was carrying one of the message. That is also very, very important. Thank you both the masters.